this session on Ondansetron. The reason we're doing this training session here is because after a consultation with the IRHA Pharmacy Department, it has been determined that we are able to give Ondansetron to all of our patients, not just patients that are part of the palliative care program. Initially, this medication was introduced to this region for palliative care, but like I said, we're able to expand it now so we can give it to all of our patients, not just palliative care. So with Ondansetron, as many of us learned in palliative care, it prevents nausea and vomiting. So nausea itself is the unpleasant sensation of being about to vomit. So you feel really sick, you feel like you're going to throw up. So nausea is caused by gastric rhythm disturbance, resulting in increased or decreased gastric myoelectrical activity. So this is caused by various stimuli such as motion sickness, toxin ingestion, things like that. So the reason we want to give a medication is to create a drug-induced normalization of myoelectrical activity within the gut to improve the feeling of nausea, to help it get back to a regular system, to help reduce that nausea stimulation in the body. Vomiting, on the other hand, is the forceful expulsion of gastric content. So you're actually moving things out of your body. So vomiting is a reflex that allows the body to get rid of ingested toxins or poisons. It can be activated by humoral stimuli, such as neurotransmitters, peptides, drugs, or toxins, or some kind of neural stimulus as well. Included in this is retching. So retching itself, it occurs when the glottis closes and respiratory muscles counteract abdominal muscle contraction to prevent vomiting. So your body is trying to vomit, but you don't. You actually just retch. So the interesting thing with these definitions is that you can absolutely have nausea without vomiting, but it's very rare to have vomiting without nausea associated with it. So with the Ondansetron, what does it do? Like, what causes us to vomit? First of all, it's really important to know this because then we can understand what Ondansetron does to prevent us from getting nausea and having vomiting sessions here. So the normal function of the upper GI tract involves interaction between the gut and the central nervous system. It's controlled at three main levels: the parasympathetic, sympathetic nervous system, enteric brain neurons, and smooth muscle cells. So vagal afferent nerves from the GI tract transmit to the medulla in the brain. From there, select neurons ascend to the hypothalamus and the limbic and cortical regions, where gastric electromechanical events are perceived as normal, or they're perceived as symptoms such as nausea or discomfort. So basically, the signal goes from your gut to your brain. It decides, hey, this is totally a normal sensation, or nope, I don't like this. I'm going to make sure the person knows that we're not feeling good. So when it comes to vomiting, the chemoreceptor trigger zone for emesis is located within the medulla, and this structure reacts when certain substances interact with those receptors in the brain. So chemoreceptor trigger zone is stimulated by dopamine, serotonin, opioids, acetylcholine, which is a neurotransmitter, and substance P. So these things can all induce vomiting. So Ondansetron is obviously classified as an antiemetic. It prevents us from vomiting, but it is also classified as a selective 5-HT3 serotonin receptor antagonist. So Ondansetron blocks serotonin receptors centrally in the chemoreceptor trigger zone and peripherally at vagal nerve terminals in the intestine. So this action prevents serotonin release in the small intestine, reducing nausea and vomiting by blocking the signals to the central nervous system. The blocking of serotonin works really well in reducing nausea and vomiting of patients receiving radiation therapy. It's used widely for post-operative nausea vomiting, and it's also usually given along with ketamine to reduce ketamine-induced nausea and vomiting as well. So it can be used for a lot of different things for nausea and vomiting. It is very effective, but when it comes to things like motion sickness, it doesn't work very well because that's a different part of the receptors in your chemical trigger zone. So it may not always work if someone's just straight up motion sick. So when it comes to giving a medication, we need two things. First, a care map to guide you to the medication. So a lot of the care maps, they're still colorized. We're trying to get rid of the color bubbles here. So as you can see what I just presented here, it's showing the pink bubbles. So that's more so directed towards PCPs. We're trying to get rid of that. So to activate a medication, basically just reference your care map. If the care map guides you to the use of a medication, take your care map, cross-reference it with the medication profile. And if they work together and it's within your scope, then you can give the medication. So the biggest care map that we use when it comes to whether we should give medication for nausea and vomiting is care map E11A and E11B, nausea and vomiting, adult and adolescent. So initially, when we go to look at dealing with nausea and vomiting in our patients, the first step in the care map here, I just took a section of it out. I didn't think I need to put the whole thing on here, is to obtain IV access and consider giving dimenhydrinate. So when it comes to giving Gravol doesn't really work too well, except for motion sickness. It's good for that. When it comes to other sources of nausea or vomiting, it doesn't work really, really well. After, again, discussing with our pharmacy department, they said basically the biggest reason Gravol works well to relieve nausea is the sedation effect of it. So basically we become more comfortable, we feel less of the discomfort of the nausea. So that's why it helps get rid of nausea and vomiting. So first go-to would be to try giving Gravol. If that doesn't work, so it says symptom relief, no, it says consider alternative antiemetics. So for alternative antiemetics, we have Maxaran. So this Maxaran is more helpful if there's GI issues causing nausea, such as delayed stomach emptying, constipation, things like that. So we talked about that in palliative care as well. So if you have a patient that's constipated due to medication use, things like that, we probably want to go more so with Maxaran because that works really well in the gut. If it's not really motion sickness, it's not something really gut related per se for your nausea and vomiting, then Ondansetron would be a good alternative antiemetic for that. So again, look at our care map. Don't care about the color bubbles right now. Look at the care map and it's saying to use an alternative antiemetic. So I'm going to do that. So I decided I'm going to use Ondansetron. So I'm going to go to my medication profile and check my scope of work to see if I can actually give Ondansetron. So for scope of work within our region, providers with EMR and PCP scopes of work may not administer Ondansetron regardless of physician order. So I am very aware that as part of the palliative care program, PCPs are permitted to give Ondansetron. The reason for that is that the palliative care trial is a specific thing to our region. Anywhere else in the province, PCPs are not allowed to give Ondansetron. So we actually have special permission from the medical director that we can get, that PCPs can give Ondansetron for palliative care. Outside of giving care to patients registered within the palliative care program, PCPs are not permitted to give Ondansetron as part of their scope of work. So again, that's a special circumstance because of our pilot program with palliative care. But again, PCPs cannot give Ondansetron outside of palliative care patients. But if you're an ICP or an ACP, within your scope of work as an ICP and up, you can give Ondansetron to your patients. And if anybody's wondering which medication profile is, it's 04.3 under the medication profiles. So we've determined that is within our scope to give this. So we want to make sure it's okay to give. So obviously the indication for Ondansetron is nausea and vomiting. So for contraindications, we have a few different things. The first one is obviously if the patient's allergic to Ondansetron, don't give it to them. It's not going to benefit them if they have an allergic reaction or a negative effect. So we're going to avoid it at that point, and we would go with a different antiemetic. If the patient's pregnant, we're going to stay away from it. The reason we're not using it in pregnancy is because honestly, there's been absolutely no human trials, actual trials, to see the safety level of using Ondansetron in pregnancy. Based on research, oral Ondansetron is used quite frequently in pregnancy, but for IV therapy, for what we're using it for, there's been no tests, so there's absolutely no idea to know if it's safe or not. The only things I could find in regards to any kind of human results from Ondansetron is that it increased the risk of oral clefts or possible ventricular septal defect development in the fetus. So as of right now, because we don't know the effect it has on the unborn child, we are not going to give it Ondansetron to pregnant patients. So if a patient has a previously diagnosed QT syndrome, so if a patient has already has a prolonged QT interval in their EKG, we're going to stay away from giving Ondansetron because it'll actually lengthen that QT prolongation. So patients that could also have this as an underlying arrhythmia, underlying factor already, if they are suffering from hypokalemia or hypomagnesia, or bradyarrhythmias, we're not going to give Ondansetron to them either. So if you're doing an IFT and you've got lab values and you know that their potassium or the magnesium is depleted and they start getting nauseous on the ride, we'd probably want to stay away from Ondansetron for that reason. If they've already been given multiple doses of ondansetron in the hospital, we may not want to give another one just because, again, putting ondansetron and ondansetron all together can lengthen that QT interval in their EKG, and that can cause problems. So it is recommended, if you are concerned about any of these, that you monitor your patient. So usually if you're going to see any ECG changes in your patient when giving ondansetron, it takes about 1 or 2 hours after the medication is given to see that change in their QT interval. But if there's any concerns at all, put your patient on the monitor and just keep an eye out for it, especially if they've been given a dose before and you're giving a second one. So we do not want to administer concurrently with any of the following medications. So if they've been given amiodarone prolongs QT intervals, so we don't want to give ondansetron and potentate that effect. We don't want to make their QT intervals longer. Same thing with giving Haldol. Haldol affects the QT interval in your ECGs, so we want to make sure we're not giving them together because that will make things worse. When it comes to giving ketorolac, so when we give Toradol, basically it's not recommended because it'll affect the metabolism of ondansetron in your system, so we're not going to put medications together that don't really work well together, so that's why we're not giving Toradol. So I talked a bit about QT intervals. So when we look at the EKG, so we have a regular EKG with a QT interval, so it looks something similar to this. So if we're going to look on the monitor and we start seeing that increase in the QT interval, that's going to cause some concern, and we should definitely be monitoring our patient. So a QT is considered prolonged if it's greater than 440 milliseconds in men or 460 milliseconds in women. If your QT interval is greater than 500 milliseconds, that actually puts your patient at risk for developing torsades de pointe, which is why we don't want to be giving these medications, mixing them together, or giving too much ondansetron, or giving to a patient that's already got diagnosed QT syndrome. Because if we put our patient in torsades because they have nausea and vomiting, that's not really beneficial for our patient care. So for ondansetron, this is what we're currently carrying on the trucks. That's not going to change. We have our 8 milligrams for 4 mLs. So when we give our medications for our dosing, if a patient is 17 years and older, we're going to give the straight up 8 milligrams. If the patient's age is 10 to 17, we're going to give a weight-based dose of 0.15 milligrams per kilogram up to a max dose of 8 milligrams. So I consulted with pharmacy, and this medication does not need to be diluted to be given. You can just give it straight IV. It is recommended, similar to Gravol, that you give it as a slow push over 2 to 5 minutes. If you're finding that it's hard to push 4 mLs over a couple minutes, you can dilute it into a total of 10 cc's. Again, it's not required to be diluted. You can give it as a straight IV injection. But again, if you're finding it's difficult to give 2 mLs or less, if you're giving it to a teenager, you can dilute it. And so with that, you would take your 4 mLs of medication, add 6 cc's of saline to equal 10 cc's, and you would slow push both together. But again, it's not mandatory to dilute this medication. You can give it straight up. So some common side effects of giving ondansetron. So it can cause headaches, fatigue. It can cause constipation. So again, when we're looking at that alternative antiemetic, as it says in the care map there, so if your patient's already constipated, we probably want to go with Maxaran as opposed to ondansetron because this could worsen things. It can cause drowsiness as well. And just some general instructions from the actual medication profile here is you can repeat it every 8 hours as required. So I'm really hoping we're not with our patients for like 16 hours. That's a long time. I really hope you're not with your patient long enough to give more than 1 extra dose. The half-life of ondansetron is approximately 3 to 4 hours, and it can extend to 6 to 8 hours in geriatric patients. So this has a really good half-life, so you hopefully should not be with your patient, again, for more than 8 hours, where you have to repeat the dose. You can give it through the IO. It is compatible if you don't have an IV, but as per always, do not start an IO just to give this. If your patient's feeling nauseous on the transfer, don't take out the bone drill to give them the bone gun there, the bone drill to give them ondansetron. That's patient's probably not going to really appreciate that. And that's all I have. I just wanted to keep this very direct and to the point here. I know everybody's very busy and you don't have 3 hours to sit in front of a computer. So if you have any questions at all, please feel free to email me. And I will answer those for you. But again, as of right now, we are now permitted to use Ondansetron for patient care within scope of work for patients outside of the palliative care program. So yeah, so thank you for watching this. And again, if there's any questions, feel free to contact me. If anybody's interested, here's the references I use for this presentation. Thank you very much. Have a good day.